Hi, Dr. Clardy. How are you?
I'm great. How are
How's your
you?
day going?
It's good. It's always busy here, right?
Yeah. So, please, first of all, thank you for taking the time to come and chat with us here at MD Newsline Podcast. Please introduce yourself to our audience.
Sure. I'm Stacey Clardy. I'm a neurologist at the University of Utah and the Salt Lake City VA.
So, tell me a little bit about the area that you focus on.
When I work at the university, I'm a subspecialist in autoimmune neurology. And increasingly, with some of the ongoing work that we're doing, that involves a lot of autoimmune encephalitis specifically. But autoimmune neurologists in general see autoimmune encephalitis, but also really any condition where the immune system might be attacking the brain or the spinal cord beyond multiple sclerosis. So very often these conditions are antibody mediated. So the immune system is generating autoantibodies, attacking really anywhere in the central nervous system. And you can imagine when it does that, it's also usually attacking systemically as well.
Mm.
So we really focus on the neurologic symptoms. They're usually the most devastating, but also really look at patients holistically because they'll often have involvement of the gut or,
Mm.
you name it, other areas of the body.
You're speaking my language right now. I want to take this step by step, though. Tell our audience what encephalitis really is.
Encephalitis, the strict definition is
Mhm.
inflammation of the brain.
Mhm.
It can be caused by really two main categories, either an infection attacking the brain or your immune system
Mhm.
attacking your brain.
Mhm. And so when we talk about infections, are these infections able to be identified, or is it sometimes a phantom infection? When someone's diagnosed with encephalitis, is it a question mark? It could be this, it could be that, or are we able to pinpoint where the infection comes from?
This is really sorry. This is really the tough part. When a patient comes in and you suspect encephalitis because they're not thinking clearly, sometimes they may have a fever or we do initial tests and they seem to show a possible inflammation of the brain. We then have to cast a really wide net because you have to very quickly try to sort out, is it an infection or is it the immune system attacking? So we do have tests we can send. In essentially every case, this involves obtaining cerebrospinal fluid via a lumbar puncture or spinal tap
Mm.
because we will test that fluid for the presence of infection or the presence of antibodies. It really matters that we do this as quickly and efficiently as possible because the treatments for infection versus immune-mediated are completely different. And if we accidentally suppress the immune system of someone who has an infection, that's not a very good thing, right? It could make it much worse. And vice versa, if you just give an antimicrobial to someone when their immune system is really revving up and attacking, it's just going to get worse from that angle too. So we have a ton of tests. They're becoming more precise by the year to test for any number of infections or in some cases sort of tick-borne or other causes of the infectious encephalitis as we sort of lump it generally. It's sort of a separate discussion into itself. There's entire lectures and sessions here on how to sort out different types of encephalitis and what tests you should order. It's not just one.
Mhm. So a patient's journey to getting diagnosed, you talked about brain inflammation. That sounds like it's kind of towards the end, like the more obvious symptom. What are the more mild symptoms, and are patients typically misdiagnosed with something outside of the encephalitis category?
This is a great question. I'll talk about this in terms of the autoimmune encephalitis side of things. And specifically, within the category of autoimmune encephalitis, there can be, upwards of, say, 30 different causes of autoimmune encephalitis. The most common is NMDA receptor encephalitis. Those patients usually have a very traumatic journey to diagnosis because they often present subtly at first with what we would traditionally call psychiatric symptoms. And so they just may begin to act a little paranoid or have a little bit of an auditory hallucination or maybe see something that's not there, a visual hallucination. And those symptoms set you on a medical diagnostic pathway that is different from seeing a neurologist who's working you up for encephalitis. So many times, just getting to the diagnosis of autoimmune encephalitis is challenging, fraught, and fairly traumatic for the patient and their loved ones.
It's one of the most surprising things that I saw when I was reading about encephalitis, especially the NADMA, what is
NMDA, it's a
NMDA,
mouthful.
especially
N-methyl
the
D-aspartate receptor. It's the name
yeah,
of the receptor that the immune system's
the
attacking.
anti-NMDA encephalitis is the psychiatric symptoms. I'm so fascinated by that because, in my mind, I often think about how, we think about emotions, for example, and these are all just hormones. Our bodies are processing hormones, right? And then inflammation happens and you're getting these kind of psychiatric manifestations. My first thought is that encephalitis seems to be at the very extreme end of the spectrum of some sort of chronic, some sort of inflammation event that could lead to psychiatric manifestations. Do you have any thoughts, or is there any conversation about how that might cascade differently, but still manifest as maybe psychiatric things? Because I know there are some papers that came out about how the brain has its own microbiome, right? I think about things like allergies, right? Some people have chronic rhinitis and some people don't, and they live in the same house, so our bodies react so differently, and we have these kind of biomes. I want to see if are there any dots to connect when it comes to psychiatric manifestations and autoimmune issues.
Oh my goodness. That question is really, really getting to the core, right? There's so much work to be done here. Um, you know, there are different flavors of autoimmune encephalitis. And to your point, one of the closest mimics of NMDA receptor encephalitis that's often considered when you're working someone up for that diagnosis is schizophrenia, right? And so when we work in this field, when we take care of patients with autoimmune encephalitis, we're confronted with every visit, with every patient interaction, with these overlapping questions of what part of this is the immune system, what part of this is your genetics, what part of this is some exposure, and why did you in this moment get autoimmune encephalitis? Now, for NMDA receptor encephalitis, for about half of the patients, we have an answer, because they, especially the young females, but even occasionally males, have an associated germ cell tumor. So most commonly, the young females will have what's called an ovarian teratoma. Some people call it an ovarian dermoid cyst. And that's what we call germ cell tumor, not germ meaning an infection, but meaning a cell that can develop in any number of different directions to become different tissues in the body. And you would expect that in an ovary, right? Because that could become a fetus, right? So about half of the young women have this teratoma. And so what happens is the immune system's gaining access to the inside of that mass. And within that tumor are cells that are basically differentiating to neural tissue and have NMDA receptors on them. And so you can imagine the immune system is not necessarily so discrete to be able to appropriately attack the ovary and not attack that exact same receptor in the brain. So that's what's going on in half of the young women. But for, the other patients with NMDA receptor encephalitis, the other half, we don't find a tumor. We don't find that sort of clear connection. Sometimes there's a story of a prodrome, we call it, like a viral prodrome, or a question of other triggers, right? This is where the human mind goes immediately. When something happens to us, we trace back to, what did I do yesterday? What did I do last week that could have caused this? And that's still wide open. Do these people have an infection? Did something happen? Did they encounter something in their environment? And it was that right sort of coalescence of your immune system in that moment, on your genetic background, And wham, you end up with this inflammation, this very dramatic inflammation. We don't know the answers to so much of what you're asking. And the other aspect of what you're talking about, the link to what we consider psychiatric disease, if you will, right? It's so artificial what we do in medicine. We have to categorize in a way in order to get to a discrete level, a diagnosis, so that we can direct treatments and interventions, right? But to separate half the brain into neurologic and the other half into psychiatric is really preposterous, right? But in some ways it feels like that at the dogmatic level. But NMDA receptor encephalitis, some of the other autoimmune encephalitides are the perfect example of the fact that that's not how the biology works, and that one receptor can control many things and can manifest in many ways. So many of the patients get behavioral symptoms, but they also can get seizures. They can get sort of the full spectrum. They can get posturing movements that we consider, movement disorders in the neurology vernacular. So many things can happen. And yes, these diseases, I hope in a way, really force us in the medical community to confront the fact that we have to be cognizant of the fact that every individual in front of us is the sum of their parts. They're going to all present differently, even if the exact same thing is going on. And there's a lot of humility in this because we don't understand why it's one way for one person and a different way for another. This is really, when I'm speaking to young people, I say, if you want to answer this question, you got a whole career ahead of you, right? You will never not have a job because it just leads to more and more questions the more we ask. So for NMDA receptor encephalitis specifically, we're fortunate that we have a clear biomarker. So we check the cerebrospinal fluid and we send off testing for NMDA receptors in the spinal fluid. They should not be there unless you have NMDA receptor encephalitis. So that makes it easier on the neurology side. It's much harder when you're making psychiatric diagnoses, when you don't have necessarily a clear biomarker.
Stepping back from neurology for a second, if in an ideal world you teamed up with a psychologist or psychiatrist and said, if we weren't working in our specialties and we had an ideal way to readjust the diagnosis process, what would you add a little bit of your process and what would you add a little bit of their process? How would you redesign kind of like the way that we think about approaching some of these things to maybe make them a little more efficient?
Yeah, this is great. And we do try to do this a lot. At the university, we have our neuropsychology division is housed in our department, which is helpful because we rely on them a lot. A lot of this comes down to time, and expertise certainly too. So yes, in an ideal world for every patient, we could spend the whole day and we could be doing team interviews. What often happens is we will do our tests. And if our tests are completely negative, then I call up psychiatry and say, something's going on here, something's not right, and then lean on their expertise because they know in detail the phenotypes of how their diseases present, what the natural history is, right? And likewise, that's what they're doing when they will send us a patient and say, something doesn't fit here. I'm afraid this is not primary psychiatric disease. And when they call us up, we will often admit a patient to try to expedite that workup. Same thing if we call them up and say, I thought at first this was an autoimmune encephalitis, but all the testing's negative. Now as I'm following, I've seen the patient a couple times, it's evolving, we're seeing less or maybe no inflammatory signal at all. Can you come in and tell me what you think? So in practice, I think this happens a lot more than people might realize, sometimes behind the scenes, sometimes by actually going to different specialists.
So when it comes to patient history, like you mentioned, so much can happen to lead to any diagnosis that everyone's a bit unique. How are we tracking the trends from patient to patient? Because we're talking a lot about machine learning and artificial intelligence, and doctors don't have all the time in the world. And from past clinical trials to maybe some novel cases and outliers and things like that, I'm wondering if there's any conversation. I'm sure there is about tracking some of this data so we can maybe look back and identify some trends based on what we're seeing?
Oh, goodness. I sure hope it's happening. I'm no AI expert, right? People spend their entire careers developing these programs, but there are patterns. I think that's what you're getting at. The way I envision this happening is the programmers and the algorithms do seek input from clinicians. I see this happening already a little bit in practice, maybe not specific to autoimmune encephalitis in my day to day, but there are patterns. It's the questions that we ask of the family and the patients. You know, was there any history of seizures? Was there any history of prior hallucinations? To determine if things are coming out of the blue, or was this the early, very, very, very early signs we might have seen of a psychiatric diagnosis? That's one differentiator, because very often in NMDA receptor encephalitis, there's no warning whatsoever. And sometimes what I've learned from my psychiatry colleagues is a good in-depth history might give them a sense of, in the background, maybe something more brewing from a psychiatric point of view that culminated and looked acute. Same thing when we're looking at, in many cases, our older patients and wondering if they have a different type of autoimmune encephalitis. The family or the patient may come to us and say, this happened so suddenly. But when we sit and spend time and ask very specific questions, we may find out that they were just a very high functioning individual. So people didn't notice, and they were able to cover up or mask a little bit of loss of some of their edge, if you will, cognitively, until it became a crisis point, and then it seemed acute. So these are the subtleties I hope that AI or data mining would be able to get at, given the right inputs. But that's what we do now, just sitting in front of a patient. We ask these questions. It's so important for us to have what we call good historians, people who know the patient very well, because they're often not well enough at the time we're seeing them to give us this history, but someone who's known them well for years can fill in these little pieces and will tell us the story that helps us to know what direction to go into diagnostically. But yeah, I think it's ripe for AI, right? Because if I can ask questions and get there, then AI should be able to do it too.
So let's talk about this gut involvement that you mentioned. So I don't want to forget that. Tell me a little bit about. It seems like the gut always gets involved, no matter what we're talking about, whether we're talking about psoriasis, the gut seems to always somehow be involved. So talk to me about gut involvement when it comes to encephalitis and just neurology in general. What does that look like? What's it usually paired with?
Yeah, I don't know if it's as much in encephalitis. It may well be, but encephalitis is presenting so dramatically with the mental status changes that we usually can't even get at asking questions about gut. These patients are in the ICU and we're just really trying to stabilize them. But in autoimmune neurology as a field, when we're talking about all of the other conditions that we treat, and this probably involves me kind of defining the true scope of what we treat. It sounds like alphabet soup sometimes, but a lot of big terms for conditions like neuromyelitis optica, myelin oligodendrocyte glycoprotein-associated disease. A lot of neurorheumatologic conditions end up in our clinics, where it may be that a neurologic symptom is taking the front seat, but when we ask, we end up figuring out that a neurologic symptom may be the first manifestation of something like lupus or Sjogren's syndrome. You were getting at psoriasis. Increasingly in my clinic, I have referrals where, again, people have a prominent neurologic symptom or sign that's really interfering with their life, the reason that they're coming to seek medical care. And you just ask a few questions and you figure out very quickly that it's part of an entire systemic autoinflammatory syndrome. But they were able to ignore the rashes, ignore the arthritis, right? They were just going about their life. They were powering through until the neuro symptom came. But then 10 minutes into the interview, it just all comes tumbling out when you ask a few questions. And yes, the gut is almost always involved. From my bias as a neurologist, I think it's because the entire gut is innervated. There's something called the myenteric plexus. So the entire way that we move food through our gut is all run by a nervous system, right? We tend to lump it more generally under the category of the autonomic nervous system, things that should happen automatically that don't. And so if the nerves are involved somewhere else, you you can bet good money that a lot of the times the nerves are going to be involved in the gut. It doesn't get the press that it deserves, and because maybe there's a more dramatic neurosymptom or something else going on. But absolutely, when you ask, it's very rarely that I have a patient in my clinic who says, "Oh no, I've never had any problems." What even is that? I'll back up. Yes, when you ask patients in the outpatient setting, especially if they're having neurologic symptoms related to their immune system, I ask all the time, "Hey, how are your bowel movements? Hey, any constipation, any diarrhea, any bloating?" The answer more often than not is yes, but again, this gets back to our silos. As autoimmune neurologists, we're trained to focus in on the neuro and then step back very quickly, because very rarely, if it's immune system mediated, is it exclusive to the neurologic symptoms. Excuse me. So very often, if it's immune mediated, it's not just going to be in the nervous system. So we're trained to step back quickly. But otherwise in neurology, outside of autoimmune neurology, we don't get a ton of bowel in our training. We don't get we're not gastroenterologists. And so maybe we don't have time in a lot of clinics to bring this up. Or maybe we're just not comfortable with it, right? Because we are neurologic doctors. And yes, that gut is innervated, but it's not a prominent part of neurology training. It really is not. And so asking about it and getting comfortable as a neurologist with asking the right questions to begin to sort out, is this the nervous system and the immune system in the GI tract? And then referring to the appropriate person for that, even within the GI specialty, because only some GI docs really like to focus on the immune system part of the bowel. It takes time, and it's something I'm still working on all the time. I tend to be informed by the patients on this. They tell me what worked, what questions the GI asked that helped get to the bottom of it. But yes, it's all interconnected. And if you think about it, the entry to your immune system starts in your mouth, right? So it's very easy to get that immune system exposure every time we eat, right? And it can just open up the immune system to a whole bunch of other targets from there.
That makes me wonder, along with what you said about, how women often get this, reaction with the cells triggering that response. I'm wondering, are there any other insights on things that trigger an inflammation response that kind of transfer over? Because when you talk about the immune system, for instance, my first thought is gastritis, right? And how over time, sometimes people don't even know that they have acid reflux, and they get all these symptoms like, I lost my voice for 6 months, I'd never lost my voice before, things like that. And over time, obviously, it degrades things over time, and it can impact everything basically if you don't know what's going on. And my thought is, then the body begins to say, oh, this over here needs a little bit of inflammation, and this over here, and I'm wondering, does that transfer to anything that then kind of manifests as a completely different immune response? Can we even kind of track that?
Yeah. The immune system is so incredibly complex. And it just knocks me down every day when I'm trying to figure out with each patient, one after another, seeing what can happen. We do have a saying in clinic, and I think all of the specialties that deal with the immune system are aware of this, and it's autoimmunity begets autoimmunity. Right? So if you have one autoimmune condition, let's take, for example, autoimmune thyroiditis. This is the most common autoimmune condition globally, when you have to take thyroid replacement because your thyroid has been attacked by the immune system, right? As soon as I hear that from a patient, I go, uh-oh, right? Okay, you've already got one. And then that helps me focus. Okay, Now you're telling me you're having bowel symptoms, right? Again, you're still a neurology clinic, but I'm going to follow what the patient's saying. Okay, what kind of bowel symptoms? Oh, are you having gastritis? Or is very commonly, oh, is food getting stuck when you're trying to swallow it? To me, already, again, my bias as an autoimmune neurologist, is your esophagus swollen? Well, what are the causes of that? Well, Sjogren's syndrome can do that. Eosinophilic esophagitis can do that. Some say, some infections play in here too. Some patients will just casually say, oh, yeah, I've had an H. pylori infection. To me, I go, why? Not everybody gets an H. pylori infection. Why did you get one? Is your immune system susceptible? Because the other piece of this is sometimes people who get autoimmune attacks have an immune system that's attacking on one end and not fighting appropriately when it should on the other end, right? So then that leads down a whole other line of questioning, or maybe they say, hey, I have 3 sinus infections every year without fail. I go, wait, that's not normal. You can get one here and there. And then I say, okay, well, what other infections do you get? You get skin infections, you get this. And then all of a sudden they've come to me for what they think is an inflammatory autoimmune problem. And they usually have that, but then we're going, why? It's a dysfunctional immune system. The immune system's so incredibly complex. We have many patients where it's an attack, an autoimmune attack on their body at the same time that they're frequently getting sick because their immune system is not attacking when it should and it's attacking when it shouldn't. And sometimes we find genetic causes of this. Increasingly, we have access to genetic testing. We can uncover that. Sometimes we still don't. We're still waiting for the genetics to catch up for some other people. And we're trying to put all this together to get the answers, but also not make the patients wait for the answers. We have to do symptom management while we're figuring out why now, right?
It's interesting. I always go back to like chronic rhinitis because so many people have it. And I'm like, are we all just inflamed and dripping phlegm? And that doesn't seem like it's okay that I feel kind of sick all the time. That feels like my body is a little bit on high alert all the time. That can't be good. Um, uh,
It's a good point, but I have to jump on what you say there. So this is why it's so important to have friends in other medical specialties, right? Who do I have on speed dial? I have the GI docs on speed dial. I have the allergy immunologists on speed dial. I have infectious disease on speed dial, right? And the allergy immunologist, that's one fellowship. It's called allergy and immunology, and it's grouped that way for a reason, right? Because the immune system can tweak in either direction. They need to be familiar with all of them. And so, yeah, when somebody tells me, oh, I have chronic rhinitis, okay, then the questions that an allergist immunologist might begin to ask are, do you also have eczema? Do you have itching? Do you have asthma? If you don't have it, does somebody in your family have it, right? Because what we're trained to do in medicine is get a phenotype, sort of get a story, do pattern recognition, right? And so is this a patient in front of us who has all those things in what we would call atopic disease? Or do you just have one piece and not the others, which is also now we're going in a different direction. Okay. Do you have chronic rhinitis because you're always having a sinus infection or so I mean, at the end of the day, for all the fancy technologies we have, I just sit and ask my patients question after question after question, and they will tell you what direction to go every single time.
So let's talk about the trial. Tell me a little bit about the trial and why it's important, what the approach is when people get encephalitis.
Yeah, so we're currently running what's called the Extinguish trial for NMDA receptor encephalitis. I am so excited about this. I eat, sleep, and breathe this trial. Literally, we have a 24-hour hotline for the trial, so I eat, sleep, and breathe it. This is sponsored by NINDS of the National Institutes of Health, and we now have all of our sites activated and enrolling. So it's 37 sites in the U.S., 2 European sites, Barcelona and Rotterdam. And we need to do that because this is a rare disease. It's for NMDA receptor encephalitis. We have no approved treatments for any type of autoimmune encephalitis, none. And NMDA receptor encephalitis being the most common type of autoimmune encephalitis, that's why we're studying that one.
Just a second.
Yeah.
It's downstairs. Trash cans.
He doesn't even have to look anymore.
Important.
That's the trash cans. That's
So, before we start over, let's talk about what the approach of the trial is. Like, what are we doing
Okay.
in the trial?
All right.
Why that's different than what
Okay.
is done before people get into the trial?
Yeah.
Okay.
So for the Extinguished trial, we are enrolling patients newly diagnosed with NMDA receptor encephalitis. And there's a lot being offered in this trial. We're trying to do a lot of things in one trial. We're trying to figure out if one of the treatments.
No.
We might have
To
to
go.
do that face next time.
Yeah.
The light's good here, though. Um,
So, yeah.
so in the Extinguished trial, we're trying to accomplish so much for the patients and the condition in one trial. We are testing one medication that we think works well, but we don't know because there are no approved treatments. But we are also trying to learn so much about these patients. So we are talking to their loved ones, finding out the caregiver experience. We are following the NMDA patients long term to understand their cognitive recovery, to understand their mood and depression and anxiety and all the things that might obviously come with an illness like this. We are collecting blood markers and creating a repository so that in the future we can go back and say, you ended up with a really severe manifestation, whereas the next person had it mildly. Can we look at the blood and might we in the future be able to predict who's going to have it severely and who's going to have a more mild case? So much going on with the trial. But for these patients, we've known about NMDA receptor encephalitis for 20 years now. Joseph Dalmau and his colleagues described the condition, identified. Should I restart? It's been 20 years since Joseph Dalmau and his colleagues identified NMDA receptor encephalitis and that the receptor was the target. And in 20 years, we do not have any approved treatments. We are still doing what we think's best, but without high quality data to inform that. And so the trial is aiming to finally bring this to the patients. I think, it's a question that comes up when we approach these families, because it's the families. The patients are too ill to have the discussion at the time we can offer the trial, and the loved ones are overwhelmed, right? Someone who was previously healthy is now in the hospital, in many cases in the intensive care unit. And they say, I don't know, there's a lot going on. I don't know about a trial. But it's so important because we cannot answer any of their questions. They say, why did this happen? What is the best treatment? How long's recovery going to take? And we don't know. And so that's the conversation I usually have. I think maybe instinctively all of us say, I don't want to.
Sorry.
Yeah.
She's not gonna stop.
At least we okay. Stop now. The minute you start talking,
She's got a laugh. She projects.
Yeah.
I'll get back to
What?
sort of.
Yeah, I'm also just to tack on later. What type of medication and treatment do people get outside of the trial? And then how can the trial kind of help them improve in a different approach to treatment?
Yeah. Right now in NMDA receptor encephalitis, if 20 patients go to 20 different hospitals, they're probably going to get as many different approaches to treating this condition because we do not have high quality data. We don't have an approved medication. And so a lot of what we're aiming to do is to come up with a standardized, safe approach that works for these patients. That's the overarching goal. And so, you really get what we call the kitchen sink of therapies thrown at you now. And so we're trying to control that because all of these therapies come with risks, right? So we're trying to understand, do you need to be exposed to all of these? Which ones are the most beneficial? Which ones come with more risk than benefit? We're trying to sort that out in the trial. So we're testing specifically a medication that depletes the antibody producing cells in the body. They're called B cells, right? And so the medication that we're studying is called inebilizumab, and it aims to knock those B cells down in the hopes that if you have fewer B cells, you'll make fewer NMDA receptor antibodies.
Interesting. I wonder, so long term right now, is is the treatment for this just ongoing? What's the ideal outcome for a patient?
Well, the ideal outcome for NMDA receptor encephalitis patients is that we get them back to where they were. What we already know from the retrospective data that we have when we look back is that it can take years for many of these patients. And this is really hard because this is a lot of young women. So it's children too, but you know, you know, a young woman in high school, maybe getting straight A's, getting ready to go off to college. You get this, it sets you back. As I tell many of my patients, like, look, we're going to put this year on pause. We're going to spend the whole year focusing on recovery at least. And then we see where we go from there. We have some data already that suggests to get really cognitively optimized to where you were before you got sick can really be years. And these are people in the height of their life, right? Just starting out, just starting a career in school when grades really matter and can make the difference for what are you going to be able to do with your life. So understanding this and getting a better grasp on how do we treat this acutely? How do we treat it in recovery? How do we treat it long term? What services do you need? What therapies do you need? This is vital.
Mhm. So is it a matter of the body eventually returns to its regular state of antibody production, which is, not at all? Or do we continue medication indefinitely to keep the system suppressed?
So this is a great question. It's just going to get louder.
Yeah.
It's going to come right next to you, actually. It's like breaking dishes.
Good.
like a
I can
Greek
empty out
wedding.
throw everything in the trash.
First
Oh, there we
five-
go.
5:40
Cool.
time.
Okay.
Okay. And just getting in the elevator.
Cool. We're
Right now, we do not know how long we should be giving immunomodulatory therapies to people with autoimmune encephalitis and specifically NMDA receptor encephalitis. We really have so many questions. This clinical trial is so important to begin to address those questions. I think back to the first patient I ever had, right? It was about 12, 13 years ago now, and I was a trainee, and I walked into that patient's room, and her mom had so many good questions. And she said, why did this happen? How are you going to treat her? Is she going to get better? Is it going to come back? Is there anything that we did to cause this? All that. We still don't have the answers to any of those questions. And so if I could get the answers for some of these patients, and this is going to keep happening, these patients are going to keep coming. If I could even get one of those answers, that would be so important, right? Because when it's your child or your sister or your loved one in the ICU, we need to do better than saying, I think, or, when we do these other studies looking back, but they're not really well controlled, we think, right? We need to do better. We need high quality. We need evidence. We need data. I want to be able to walk into the room and say, I'm going to give you this medication right now because we studied it and we know that's the right thing to do.
What are your biggest roadblocks to moving to the next step in your clinical trials? What is your ideal next step? And then what are the challenges?
We're enrolling right now in the trial. The hardest thing is awareness of the trial because everybody who gets this condition has never heard of it the week before they had it. The family didn't know about it. Same thing sometimes with the doctors. And we need to identify these patients right away. And it's a tough period of time. They get the diagnosis, and the next question, as soon as any of us get a diagnosis, is, okay, how do I treat it? So then we have to come in and say, well, about that, we're not totally sure, and here's a clinical trial. And so really raising awareness to patients, to the patient loved ones who are taking care of them, because as we said, the patients aren't well, and to the clinicians is essential. And it's such a hard thing when patients are so sick and in the current healthcare environment, to get the word out to doctors, hey, there's a trial site near you, but can you drop everything and call the hotline and talk to the patient family about it? These are really hard things in a busy medical care system. So that's why we have the 24-hour hotline. That's why we're constantly doing outreach. That's why I implore my colleagues to say, look, you can't give standard of care to these patients. You can't call something standard of care unless you're letting them know they can participate in a trial.
How do people, what's the number for the hotline, and what are some of the questions that people often have, questions or misconceptions about the clinical trial?
Yeah, this is a great question. The hotline answer, that's the easy part of that question. It's 844-4-BRAIN-5.
844
4
brain
brain 5.
So
All right?
3 4s and then brain 5.
Yeah, we worked a while to get one that we could
8
remember.
4 brain 5.
Yeah.
Yeah.
And so that's the hotline, and we do answer that. We staff that around the clock. We get calls from doctors that get a positive result back, say, hey, I saw this written on there, or I Googled it. We've gotten calls from loved ones who said, hey, the doctor just walked in and said this. I immediately got out my phone. I Googled it. Up popped the trial. I've got questions, right? I think in today's day and age, the biggest challenge is mistrust of the healthcare system. So you have often a traumatized family because that patient has gotten sick. They are hallucinating. A lot is going on. They're thrust into this medical system in crisis. And then we walk in and say, hey, you want to do a clinical trial? Well, that can feel like, no, I don't want to be a guinea pig, right? But you got to step back and realize who participates in clinical trials. If you look at who benefits from clinical trials around the world, it's usually a medically savvy, sort of privileged folks who get access. So you got to ask yourself, do they want to be guinea pigs? Probably not. So why are they participating in a clinical trial, right? What is it that trial can offer to me or my loved one? That should be the question that we're all asking. Tell me about your trial. Tell me why we need a trial. If there's already 10 approved medications, then maybe I'm not going to be in that trial, but there aren't for this condition. We're still learning. There's nothing approved. We don't know which medications we should be learning. I'm sorry, we don't know which medication.
Pause on the things we know. What could be happening? What could it be?
It's fine. For this condition, NMDA receptor encephalitis, we don't know the right medications, when to use them, how long to keep people on them. We don't know any of that yet. And so in a clinical trial, that's what we're trying to figure out. But also you're getting access to a team who's dedicated to this day and night, right? Who's going to follow the patient, your loved one, long term, right? We are meeting with this trial all the time. We have this hotline. The Professor Dalmau, who's the one that discovered this, is participating in the trial, right? We desperately want to know the right thing to do. That's why we're doing this, right? But in this era we live in of medical mistrust, I get it. I get it. People hear clinical trial and they're like, I don't know about that. Right? I would probably do the same. So I would just encourage people, ask the questions. If somebody offers you something, why? Why should I? What would you do? Right?
Is there a cost to this financially to participate in clinical trials? Because, insurance
right.
and cost usually come into play when people make care decisions, unfortunately. What does that look like for a patient who's facing this, has probably gone through a battery of tests that, is covered at various things just to figure out what is actually going on? Maybe they have an answer and now they're like, oh, there's this other thing you can do. What does that look like for them financially?
Yeah. I think in the clinical trial space, the short answer is you're not incurring extra costs. But in the clinical trial space, we have to be very careful about this because part of that following the patient long term involves more visits than you would otherwise get if you weren't in the trial. Now, to me, that's all benefit all the way because you are being watched so closely. You are being followed. You are getting access, right? If something goes wrong, if there's a concern, you have access. But that does mean, now all of a sudden, if you live an hour away from the hospital, the academic center, where the experts are, you've got to get there. And so what I can say is we spend a great deal of time as a trial team making sure that the participants get access to what they need and are not overly burdened. And it's a different situation for every single participant in the trial. So we have gotten very creative in getting these patients the care that they need.
How is this work funded?
So our trial is duly funded, and that's been important and such a benefit. So it is an NIH sponsored trial. It is an NIH funded trial. What does that mean? When you get to the basics, taxpayers. The taxpayers are paying to support NIH. NIH said, you know what? This is a disease for which we have no approved treatments. Yeah, we need to study it. So it's an NIH funded grant that pays for different aspects of the care at each of the sites. And then the pharmaceutical company that makes the compound inebilizumab, the one that we're studying, has also on the back end offered to provide that drug for free and to support some of the trial to help.
You're doing great. And
I get a break like
gonna
every
wrap.
3 minutes.
we're gonna wrap soon.
I can say that. Do you want me to say that again?
The pharmaceutical part. So yeah.
And then on the back end, the pharmaceutical company Amgen, who makes inebilizumab, is supplying that drug for free, and they are also supporting some of the auxiliary services of the trial as well. That's a new one.
It's like an opera singer next, I feel like.
That would be good, at least.
Yeah.
That would.
And feel free to tell me how comfortable you are getting into this, because I think that that's a blind spot, right, in science communication when it comes to understanding how science works for people who might end up participating in clinical trials. There's such a pharmaceutical companies are a big black box, and they're often evil, quote unquote, right? But then we go to the doctor and we need medication. And so there's not really the missing link is, how does a pharmaceutical company that's known in the news mostly when they're doing things that are unsavory or jacking up prices or giving us medication that we don't need, how do they come up with this medication that you're then like, and we're going to try it for this? Can you bridge that gap for me a little bit?
This is a great question, right? And I think it's our tendency to oversimplify things. How does scientific development come about? Well, some of it comes through our federally funded research programs, for sure. And that's at the backbone of many subsequent development of drugs that is done by a pharmaceutical company, right? And at the end of the day, there are people investing in those pharmaceutical companies. And so that aspect of it, which we try to stay sort of away from in medicine, they're going to need a return on their investment. So some people say, oh, I'm never going to talk to or consider or interact with a pharmaceutical company. And that's fine. But without those pharmaceutical companies, we wouldn't have most of these drugs, right? So we like to make everything so black and white, right? You're good, this person's evil. We all know that's not really how it works, right? It is nuanced. And so this is something you need to face, right? I get it. I have the same sort of impulses sometimes and the same sort of gut knee-jerk reactions. But the beauty of this trial is that the need is so great in this rare disease that everyone has come to the table and they're collaborating. Right.
What was the medication originally used for, and how did the idea to use it for encephalitis come about?
Right. So inebilizumab is a whole class of medications. There's many in the class called B-cell monoclonals, and so they deplete the B cells, the antibody-producing cells. Inebilizumab is approved for other indications. One of the conditions that we treat in neurology called neuromyelitis optica spectrum disease, it's approved for, and it was just recently actually approved over in the rheumatology space for something called IgG4-related disease. These are all rare diseases, right? And no one entity alone is going to be able to bring treatments to the rare diseases. It's going to have to continue to be collaborative. Business, government, funders, even benefactors. This is what needs to happen. Everybody has to partner in the rare disease space. That's the reality of it. We're not going to make progress if one person tries to go it alone in their silo.
Well, this has been great. Is there anything that we have not covered that you're like, I really want to make sure or are there any notes that you have verbally for our process just to make sure if there's anything that you said? You can also send me a message about this afterwards.
I think in NMDA receptor encephalitis, it is a rare condition. We have this unique opportunity
Mhm.
to study it. I can say that again. NMDA receptor encephalitis is a rare disease, and we have right now a unique opportunity to study it. And if we don't take that opportunity, I'm not sure it's ever going to come along again. And so as a community of clinicians, neurologists, all the specialties, we have to sit down, confront our biases about what we think we're doing right, how we think we should treat things that's not evidence-based, it's not high-quality data, it's not what we call prospective, double-blinded, randomized. And we need to take the time to sit down with these patients and families when they present and say, this is where things are. Instead of just running in the room and saying, well, the last 3 patients, even though there's no approved treatments, I did this and they seem to get out okay. And so that's what we're going to do here. And in a busy clinical practice, you can see why that might happen. And so it's a big ask, I think, of the medical community to say, sit down, look at the trial, discuss it, get them access, give them the hotline. But if we don't do it now, we're not going to be able to get anyone to give us the chance 5-10 years from now and say, oh no, let's go it again, right? We have to work together, and we have to be dedicated to this now, because this is all a medicine. We wouldn't have any approved treatments if we didn't always say, what's my data? How can I make it better? Right? That's where we're at with this rare disease. And because it's rare, I think there's a tendency for people to say, oh, we can wing it. Maybe we don't need high quality data. And that's not true, right? We'll never make progress for these patients if we don't focus.
When you say that we have an opportunity we might not get it again, is that because you feel like, if we don't jump on this now, we'll have to start over with fighting for its priority and funding? Or what does that mean, that a window closes and then it might not open
It's
again?
all the things, right? Right now we have the interest of, pharmaceutical development. We have the interest of some of the federal funders. We have a moment in time where we have good candidate drugs to test. That wasn't always the case either. And all of those things coming together, that doesn't happen every year. That doesn't happen, right? It's an opportunity that the people that came before me were working to develop. Here we are now. And the other piece of this that maybe we don't talk about enough is the longer we keep practicing without data,
Home stretch. The thing we don't talk about often is
yeah. The thing that we don't talk about much is the longer we keep going on practicing with our biases as clinicians, the best thing I did last year is going to inform me doing the same thing this year, even if there aren't trials. The longer I do that, the harder it is to break that bias, to break that habit. I talked to a patient just last month, and they said, what do you mean the drug my doctor gave my daughter, as it were, for NMDA receptor encephalitis isn't approved? That's impossible. And I said, well, actually, no, there's nothing approved. And she was shocked, right? Which to me means that, right, we're just, as clinicians, saying this is the treatment. And the longer we do that without data and without questioning and without striving to improve and learn more, it's dangerous, right? We're just going to get stuck in the habit of doing the same things over and over because that's what we did before. We've got to do better. I have to be able to walk in that room and say to that patient and their family, we studied this. And the people who had this condition before you, they were willing to study this because they wanted you to have an answer to the question I didn't have the answer to for them, right? But we've got to do it now, because if we don't get it together as a community and show, the funding agencies, show the patients, show everyone that we're committed to do this, we're going to do it right, even though it's hard, they're not going to stick around and say, okay, take your time and do it again in 5 years, right?
Yeah, it's great. Thank you so much.